All right. I'd like to do some introductions. It can be difficult in an online format for everybody to introduce themselves because everybody tends to talk at once. If you don't mind, I'm going to take it off of share and then go ahead and just kind of go around the room and introduce everybody. All right. My name is Steve Hart. I'm the program director of the Respiratory Care Program at St. Petersburg College. We have Rachel Townsend joining us, who's a therapist at St. Joseph's Hospital in Tampa, Florida. We have Jean McAgay, who's the director of clinical education at St. Petersburg College. We have John Wilkes from the Florida Hospital Association. We have Tom Seelig, manager at Shands Hospital. We have Rob Walsh, who is the director of clinical education. Rob, I'm sorry, I'm embarrassed to admit I forgot the name of your college.
Oh, that's fine. Indian River State College in Fort Pierce.
Okay. Welcome.
Thank you.
You mentioned Mark Allen. We have Aaron Sterling, who is with, I'm sorry, Aaron.
I'm kind of a miscellaneous. I was a program director in North Carolina, but right now I'm actually working on a sort of a interactive online study textbook situation.
Okay, very cool. Very cool. We have Amanda Dexter, and again, I'm sorry, Amanda. What company are you with?
Sure, I'm new to Florida as well. I am the new program director for the master's program at JU that we're launching next January.
Oh, welcome.
Thank you.
I'm waiting on the Zoom trying to get in.
Okay.
That's not.
Okay, we also.
So is Jean.
Okay. Hey, everybody. I'm also admitting Misty Carlson, who is the DCE at Daytona State. And I have Jean Newberry, who is the program director at Florida Southwestern. Is there anybody that I forgot? Did I admit anybody, mispronounce any names, anything like that? Okay, very good. All right. Just a couple other things that I wanted to take care of by way of housekeeping. All right. One is I'd very much like to have a hard stop at 1 hour. So I'd like to start promptly, at 2 p.m. A couple of reasons for that. One is that shorter meetings tend to be more productive. Two, at least around here, it's a beautiful Friday afternoon. And I'm sure there are many things we'd all like to get to. Thirdly is there are going to be people that will be using these recordings to help catch up, either to educate themselves on the work of the committee, or they are committee members who want to catch up, and just shorter recordings just make it easier. If you would, when you speak, just state your name for the recording, so those that are attending by recording are able to realize who's speaking. We have a fairly good distribution across the different disciplines of respiratory care. Dr. Tom Furman will be joining us to represent the medical community. We have a pretty good geographic distribution. I would like to see more bedside clinicians and students. So if you would, please spread the word to your employees and students. And I also want to apologize to the folks in the Orlando area. As you folks know, planning a big meeting can be difficult because everybody has conflicting schedules and commitments. And unfortunately, we had to choose a day. And when the final decision on the day came down, it happened to land right on the day when the RT programs in the Orlando area were having their advisory committee meeting. So unfortunately, Orlando area is underrepresented today, but we look forward to having them join us in the future. I also want to kind of make a correction. The name of the committee and the degree itself is often referred to as the Bachelor of Science in Respiratory Therapy, very commonly abbreviated to the BSRT degree. According to the Florida Department of Education, that degree, which is known as the BSRT in many states in Florida, is technically referred to as the Bachelor of Science in Cardiopulmonary Sciences. So instead of the BSRT degree, I should be saying the BSCS degree, but the BSRT degree is just so much easier to say. I am very excited to hear about what's going on nationally and in some other states regarding the APRT. I look forward to having those discussions in the future regarding the advanced practice respiratory therapist. But I just want to ask, for just the sake of having good, clean meetings, that the APRT be kept to a different discussion. I think that's certainly a discussion that we need to have, but I think it's very much a different discussion. And I'd like to ask that if this format works out and we're all pleased with the progress of the group, that perhaps we could reconvene at the end and actually tackle or start to tackle the APRT here in Florida. We'll talk about the work of the white paper. I want to let everybody know that they're kind of off the hook. I've sort of gotten together a smaller group that is committed to helping this committee produce a white paper. Now, don't misunderstand. Anybody who wants to be involved is more than welcome to help us produce the white paper. But I want to let you know that this is something that we'll be working on separately. If all goes according to plan, we hope to have about 3 to 5 meetings. During that time, the white paper group will be starting to grind out the outline of the white paper. After about 5 meetings or so, we'll take a little hiatus, work on the white paper, then reconvene the whole group, look at the white paper, make sure everybody's satisfied with the white paper, make any final edits, with the goal being to produce the white paper by the end of the year. I want to mention for those that may be aware that here in Florida, we're kind of a unique situation in that unlike many states, we have an abundance of bachelor's degrees in respiratory care. Here are the logos of 11 schools that currently offer bachelor's degrees for respiratory therapists. So one of the challenges Florida does not have that many states do is access. There are certainly many fine programs out there for therapists in Florida who would like to continue their studies locally, not to mention any number of fine national programs online. I also want to take a minute and briefly give credit to whom credit is due. All right, I want to thank the Florida Society of Respiratory Care for their work in helping plan and organize this. I also want to thank at least the individuals listed here. About 5 years ago, Kim Harvey from Valencia and I served on a committee for the COBRA, which is the Coalition for Baccalaureate and Graduate Respiratory Education. All right. As part of that committee, one of the things I was tasked with was to talk to the different states and find out where they were as far as their state efforts to advance the respiratory baccalaureate. And the folks listed here were very helpful on that. I also want to thank John Wilgus from the Florida Hospital Association, who's on the call today. Who was also kind enough to help me sort of organize this and take a look at what I had and offer some excellent feedback. So thank you for that, John. For those of you that may not be aware, back in 2019, the New York State Society for Respiratory Care elected to introduce a bill to the floor of the House of the New York State Representatives, basically to convert to the BSRT as entry level within the next, I believe, was 7 to 10 years. I haven't been able to follow up on the current status of the bill. I understand that it is stalled. All right, but that was the path, excuse me, that New York State took. Steve Smith has done some very good work in New York State as far as moving that state toward the BSRT as entry level, and we'll see where it goes. Our counterparts in California, the California Society of Respiratory Care, had a very similar workforce meeting. They issued by all accounts, an excellent white paper on the efforts to advance the baccalaureate in California. They issued the position statement that you see here. Their hope, and again, I don't know where this is with COVID, but to move to the baccalaureate as entry level by 2030. Right. So a couple of things that these folks had to share with us was one about a big part of what we're doing here today, meeting, talking about different plans, issuing white paper, is to make therapists aware of the issues involved with the BSRT so that they can basically be more knowledgeable about the topic and make their own decisions regarding the BSRT. There was also a lot of discussion with some states versus state solutions versus national solutions. Some states have elected to basically be very, very proactive and try to reach a state solution. Other states have been less so and are looking for more a national solution. Each state that I talk to at least seems to have different assets and liabilities. So it's likely that the state solutions will tend to be very customized. I was also advised to, and certainly hope to, keep the national agencies like the AARC and COBRA advised of our activities. Real quickly, the role of the white paper, again, is to serve as a source of information and education for those here in Florida wanting to learn more about the status of the baccalaureate. Also to serve as sort of a resource and maybe a guidance documents to schools that may be considering switching to the BSRT or beginning to offer a degree completion program, and practitioners that may be trying to decide whether the BSRT is right for them. I know as a member of a group that spent the last couple of years pushing an application for a BSRT program through the state DOE, this would have really helped. Had we had a white paper that we could have shown to the state that, listen, folks are talking about this, that would have been incredibly useful. And for example, Misty just let me know that Daytona State is working on offering a program in fall of 2023. All right. And as she goes through the process, having a guidance document like this could be incredibly helpful. The other thought that we discussed was that if something else happens in respiratory that may lead us to open the Respiratory Care Practices Act, whether that be the student exemption, or whether that be the RRT as entry level, or whether it even be the APRT, it would be nice to have a white paper on the BSRT. So if the best option we come up with involves opening up the Practices Act, we would be ready to, if we needed to open up the Practices Act for something else. So really, when it comes to white papers, it would be far better off to have one and not need it than to need one and not have it. Other states are watching what we do. Some states feel that Florida has some natural advantages here as far as reaching a state solution, again, mainly because of the large number of programs either online or coming online. It also creates a record of our progress, lets people know where we're at in the whole progress. So to kind of wrap it all up, basically our mission is to create a listing of conditions that any plan to promote the BSRT in Florida must meet to be successful. Basically, it's a wish list that our solution for a BSRT or our solution for advancing the BSRT must do this, whether it's avoiding a decrease in the number of practitioners or anything like that. Then develop a list of solutions that checks the most of those boxes. This is what we would want to see in a solution. These are proposed solutions. What matches up best? Recommend the best solutions. Produce a white paper on that and make that available via the FSRC and other organizations to the practicing public. And there, I finally get to shut up. Is there Are there any questions? What questions do y'all have for me? You guys are thinking of questions. I'm going to go ahead and answer a couple of texts here. Questions for me? All right. Well, let me throw a couple of questions out there. What is our wish list? What does our plan need to include in order to be successful? Okay, now I just got a text from Dan Ayers from St. Joe, who has joined the call and is looking to get his audio working. I know one of the things that Dan and I had talked about offline was that any plan should avoid a gap in clinical practice opportunities for students. So we would want to avoid a situation where students went 2 years to school, went to clinicals for 2 years, then had a 2-year hiatus while they finished their bachelor's degree and didn't have any clinical time during that. So they would enter the clinical arena just rusty can be. So on Dan's behalf, I'm going to put on the list, no interruption in clinical education. What else should be added to that list? Hopefully everybody's finding their unmute buttons.
Hi, Steve, it's Misty.
Hey, Misty, how you doing?
I'm good. So a question that I get a lot about this is, if we went to bachelor's entry in Florida, what would happen to people that, didn't want to go to a bachelor's degree that are currently working?
Okay. I think one solution would be to grandfather in all existing RRTs. And I want to, if you don't mind, Misty, I want to take a minute and kind of define the term grandfather.
Right.
I know that when we looked at the RRT as entry level, the term grandfather caused a lot of confusion in the survey we did. So I want to let people out there listening in radio land know that when we talk about grandfathering, basically what we're saying that, listen, if you're an RRT that has graduated from an AS level program, you are going to be able to freely continue to practice with that credential. No one is going to force you to go back for your BSRT. You would be able to maintain licensure as long as you met the terms for licensure, such as your CEUs and everything like that. Does that make sense?
Mm-hmm. I kind of figured that would be the case. I just wanted to make sure that other people agreed with that, or if that's what the purpose of this was, because I get that question a lot.
What say the rest of you? What do the rest of you think on that matter?
No, I agree with that.
Okay. So Tom just weighed in and said he agrees that grandfathering would be a minimum requirement.
This is Jean Newberry. I agree too. I think there has to be something, but it may come down to what employers want as well. They may end up doing, like where they won't hire a CRT anymore. They may eventually not hire ASRT as opposed to a BSRT.
That's a very good point, Jean. Thank you for bringing it up. So when I say you would be free to practice, that assumes, as Jean says, that your employer, wouldn't put an additional requirement on you. There may be those that if the BSRT did become the minimum entry level, there may be those hospitals or even departments within the hospitals that would ask that people become the BSRTs. Similar, like as Jean says, happened with the CRTs. Other thoughts on that, on grandfathering?
It's Misty again. So if we said, yes, you grandfather these people in, but then a lot of people have moved positions, and then the hospitals also start to say, we want bachelor entry only, then where are these people gonna go work?
Phew, that's a good question. Anybody else want to weigh in on that?
Yeah, I can kind of weigh in from our standpoint as I think that is a very valid concern because that does happen in facilities currently with the CRT versus RRT. We have a few CRTs remaining in our organization, but in order for somebody to come in with a CRT, that's not an option. They would
Right.
have to stay within their same facility or find another facility that still allows that credentialing.
Hi, this is Mark. I'd like to add one more point though, because I'm certain all of us directors are in the same boat in this regard, is the lack of resources out there as far as respiratory therapists go. I don't foresee this even in near term as changing. So likely a concern of not having a place to work, there wouldn't be much need for that.
Yeah, good points all. Good points all.
This is Dan. Can you hear me?
I can, Dan, loud and clear. Hey, Dan.
Yeah, sorry, I had some problems switching from to Zoom. So what the question I have is, I'm just curious, I'm just concerned about the timing, and you may have addressed this in the beginning. With such a shortage of, it seems like, available RTs right now to fill the positions we have, I'm not sure if this is the right time to be putting what could be more barriers to entry into the field. I'm not sure.
No, I think that's a good point. I think, John Wilgus has a message out there, do no harm. I think that's an excellent point. I think one of the things that needs to go on the list of what any solution would require is that it can cause a decrease in the number of available practitioners, right? Because nobody can afford that right now. We're already so short. So I would think one of the things that a solution would require would be that it doesn't reduce the number of available practitioners. Now, we can talk about different solutions that check that box later on, but I think that's an excellent point.
Right, and I see John's message here that there's a way to provide an exemption for the grandfathering, and I agree with that, but I mean, even just entering, I think that could, if people were like, oh, they no longer train to the associate's degree, because that's what you're proposing, that the schools at some point stop the associate's degree credentialing, or
I think
within the state?
I think that's one of a couple options that are being discussed. There's talk about the BSRT entry level, similar to what New York did. I don't think you have, in my opinion anyway, and I'm interested to see what the rest of you think about this. I don't know if you have to go all the way there. What if you were to say, and I'm just throwing this out there, in John's speech, what if you created an additional level of licensure?
Okay.
What if you said, okay, you can go 2 years, you get your ASRT and you become an RRT, all right? You go out there, you work at a hospital, and then then you have the option of going back to school at any number of the 11 degree completion programs in the state of Florida and get your BSRT. And of course, you're continuing to work this entire time, you're continuing to gain clinical experience. And then after that, you're eligible for a higher level of licensure. For the sake of argument, let's call it a BSRT or something like that. So instead of having 2 levels of CRT, RRT, you would have 3 levels, CRT, RRT, BSRT, and then eventually you would have to look at closing that level of CRT and reverting back to 2 levels. That would be another option. I'm just throwing that out there as an option other than the RT is minimum entry level. It seems to check a lot of the boxes that are being discussed.
Yeah, I think that, because that was at one time, we've been through different versions of this. That was one time the proposal, which I kind of think in this current environment is a more realistic, because it still leaves the same entry into the field for the different levels that we currently have now, even for places that I guess there a CRT level too? For places that still hire CRTs, but at least it sets a baseline for future saying, okay, we're gonna at this point in the next 5 years, we're phasing out CRTs, and then the next 10 years, we're phasing out the associate's degree or something to reduce the licensure. I mean, you know, yeah, I mean, that would be, I think, the most realistic right now.
Yeah. John Wilgus posted something I find intriguing. What if he said, and John, please correct me if I'm misstating your position here, that you say, listen, let's create for right now, you have CRTs, RRTs. You create the third level of BSRTs, you have CRT, RRTs, BSRTs, but in 5 years, you would say no new CRTs, you would grandfather in all the existing CRTs, you would let them basically, over time, attrition would eventually phase them out because there are fewer and fewer of them. So eventually you would just end up with BSRT and RRT. And I know I promised I wouldn't bring up the APRT, but then eventually you could look at maybe adding the APRT. It seems to me like it checks a lot of boxes. So
Yeah, I agree.
the other thing,
I feel that would be a better option than just phasing it out completely. That, as Dan said, and I think John was mentioning as well, is we still need to get therapists into the profession. And if we tell them that it's going to be 4 years before they can get started, I think we may start having issues with enrollments.
That's my concern, is we already have, I don't know if everybody else does, but we already have issues with enrollment. So if I say it's a 4-year degree, everybody's going to go rad tech and all the other programs that are 2 years.
I agree. Now this is the part where everybody affiliated with SPC kind of rolls their eyes in the back of the head, because Steve Hart's going to talk about Perkins Money, I guess. But I want to make sure everybody on the call or listening out there in radio land understands the role of Perkins Money in respiratory care education. So Perkins Money is a grant that the federal government gives to 2-year RT programs, so they can purchase stuff because they are 2-year programs. So if you walk into my ventilator lab, every ventilator in there was purchased with Perkins Money. I get hundreds of thousands of dollars coming into my program every year through Perkins Money. The day you say the new entry level is BSRT, that money walks out the door, and that's a sad day for Steve Hart and educators across the state. So the other thing about the solution that we're talking about would be that it would allow programs to preserve their Perkins money. And you know, Gene, some of you other program directors out there, that's huge, right? I mean, you guys live off of Perkins money as much as we do over here.
Absolutely.
Yeah.
So, and that would hurt, right, Rob? I mean, I suspect you guys probably rely on a fair amount of Perkins money too, right?
Yes, sir. Correct.
Right, and I agree, and I hear that's a really good point, but the big driving force to bringing our profession up to the bachelor's degree, just to let you know from a hospital standpoint, management wise, is if the majority of your therapists or entry level is bachelor's degree, there is the potential for lobbying CMS to have direct pay for respiratory therapists, which is something we are not entitled to right now, because the federal government only recognizes the baccalaureate and higher as you know, a true profession that is eligible for, you know, pay for service, I guess is the term that they use, or whatever they use, where right now we can only charge for DME and those types of things, and very limited services. So that's really the end point, at least from a hospital standpoint. Correct me if I'm wrong, but I think that's why we're moving in this direction.
I agree, Dan. I agree. And I think that has to be the eventual goal, because getting CMS and Medicare to recognize us as a profession and reimburse us for our service is going to require a baccalaureate degree as entry level.
And that would be nationally. So I know we're way light years away from that right now, but that's what our hope is at some point.
But in your points well taken, again, that's the goal to which we as a profession have to aspire. We may not be there yet because of just the shortage of practitioners, but that's where we have to go.
Correct.
Yeah, that's a good point. Something always to keep in mind. I just want to take a minute and kind of catch up with some of the chat posts and everything like that. John Wilgus isn't able to come to his mic, but he's got some excellent points I want to share with you. He says, I would not include any language in the Practices Act about a time frame that phases out anyone. That is an excellent point that I think if you start proposing language be added to the Practices Act about phasing out CRTs, your chances of getting this through go way, way down. And some of you that are maybe a little more familiar with this than I am, like Mark, would you agree that's a true statement?
Yeah, sorry, I was trying to find my mute button. Yes, definitely. And again, as we have this discussion, I know we've been down this road partially and for years and years. I wonder, again, our nursing partners, I know I've mentioned this before, but our nursing partners are taking a different path with magnet status and such, pushing their degrees forward. And I wonder if there's another avenue besides opening our Practice Act that we could explore to help us along this way, especially in light of our different world now post and during COVID.
Yeah, I agree with that too. So, does anybody else have anything they want to interject? Because I'm kind of rooting through the everybody's excellent points in the chat, getting ready to kind of throw them out into the public forum here. A couple other points. John Williams, there's room in the tent for everybody. AS programs, BS programs, and graduate level programs in clinical and management. Yeah, I agree with that. I definitely agree with that. And I think Aaron raises another, I think, excellent point that there may be students that prefer a flat 4-year degree, that there may be those students that say, listen, I want to go to a 4-year degree and get it done. So if I'm understanding Aaron's post right, she's saying, listen, there may be a place for just flat 4-year programs, where somebody can just go 4 years and get their degree and be done with it. Aaron, is that a fair representation of what you're saying there, or have I completely misunderstood your post?
No, you're right. I think there are some students that, especially in high school, who want to go into healthcare. They plan to go to college. They don't even ever really see RT, especially because if they're not considering a community college where the most of the associate RT programs are, they may not even really realize that is an option for them if they want to get an entry level BS, but in a different healthcare position, something that they might not have considered. And then the other thing are the students. There are lots of students right now who are changing careers, who, especially with COVID coming in, they kind of learned about RT for the first time, who have degrees, bachelor's degrees or associate's degrees in something else, and don't necessarily want to go back and get another associate's degree. So I've seen a lot of conversations about that as well, in terms of, I want an entry level BSRT, like where can I find an entry level?
I have a question for the group, mainly for the educators, but pretty much anybody. A few years ago, when we were looking at the bachelor's programs, we were looking at how many of the bachelor's programs were actually going into the field of respiratory versus using it as a stepping stone for another profession. Is there any current data on that?
Not that I'm aware of. What, Gene, Rob, Missy, have you seen anything like that?
No, I'm not aware of anything either.
Okay.
Jumping off that same question, and I may have missed that, but is there data or numbers that's current regarding the percentage of employed or, respiratory therapists in the state that have a bachelor's degree right now? What is the percentage of that? Does anybody know?
I don't have it immediately at my fingertips. I could find out for you. I have seen some national data on that. So that's something I could track down for you for the next meeting. The one issue that comes up there though, Dan, is some of the therapists that technically have bachelor's degrees have bachelor's degrees in other fields. And one of the questions I get asked a lot is that, what do you do with those therapists? So that somebody's a working therapist and they have a bachelor's degree in, let's say, history. Do you count that as a bachelor's degree? I've done some research on this topic. One of the things that our school is looking at is you could simply do an advanced post-baccalaureate certificate, give them 12 or 18 credits in respiratory, and that could be used to meet the requirement for a respiratory baccalaureate.
Yeah, so that brings up a whole nother ball of wax. That just, again, it's a management question. It's probably, it's more of a pet peeve than anything, is like, are we doing ourselves, we want to advance the career to the baccalaureate level, but at the same time, as a manager working in an acute care environment, it's important that the bachelor degree is like either the advanced cardiorespiratory science, or it has the minimum sciences required by CLIA or CMS or the governing bodies of CAPS and Joint Commission to be supervisor for moderate complexity blood gas lab. I'm sure people are aware of what I'm talking about.
Yeah,
This is Misty, and I have something to bring up about that, actually. Our manager at one of our facilities just brought this up the other day, referring to CAP accreditation, and that CAP's been informed by CMS that all respiratory blood gas labs that perform moderate complexity testing must have an individual with one of the following degrees, either in chemical, physical, laboratory science, or medical technology. So that doesn't even include the respiratory therapy, cardiopulmonary science degree anymore.
Well, no, it does, because there's an or statement, unless something has changed since I think 2017. There's usually, or you have to have so many credit hours in a physical science, such as microbiology, chemistry, anatomy and physics. I'm not even sure if anatomy and physiology is listed, but there's
this just came to me just the other day because he's dealing with CAP right now, and the CAP inspector stated that it could be a consultant, like they could have a consultant, but that this was something totally new to him, that he wasn't going to be able to use cardiopulmonary science. That's what he told me. And that's why he was reaching out to us to ask if I had like a different degree other than respiratory, and our program manager as well. So this was something that just like.
So what degrees are they taking, Misty?
Chemical, physical, clinical laboratory science, or medical technology.
Wow. So not even like a biology degree wouldn't cut it either then.
Yeah, and so he said, this is not a new ruling. It's been required for some time. They just never looked at it in depth.
So Misty, I have a feeling there's many different, they challenge that, because some of it's still the same. It changed in about, I think, 2017. think I have it in front of me. And I have the wording, but there's often the inspectors get it wrong.
Okay, and that's why he was questioning, so I thought I'd bring it up in this meeting.
It's
Because
not just
if-
any bachelor's degree in respiratory. It has to be
Right.
one that has, usually it's basically the ones that have 3 years of a continuous core science, like chemistry, microbiology, anatomy and physiology, those types of things. And it usually has to have, 3 years of it or something like that.
If maybe you could send that to me so I can like send it to him, because then he would,
Let me see the date.
I don't know, 'cause
Well, this
he's
one's
just dealing with-
2015. Yeah.
he's just dealing with some new inspector, maybe, I don't know. Because we brought this up in pushing for our bachelors is for CAP being able to be that person at a facility. And we brought
Yeah.
that up to the school and said, this is one of the reasons we need this. And then he's bringing this to my attention and I'm like, I don't know anything about it, but I'll look into it.
I'll send you I have the AARC blood gas analysis and respiratory therapists explanation. It was like a white paper they kind of sent out. Can you just put your email in case I don't have it
Yeah.
in the chat, and I'll
Sure.
scan it to you. Unless somebody else knows that's on the call of some new Tom or anybody that maybe have had this
We just
another
went through our
version of this.
I'm sorry. Hey, Dan. So this is Tom. We did actually just go through our CAP inspection, and one of the things that they did mention is that we had to have a bachelor's degree in medical technology, clinical laboratory science, or chemical, physical, or biological science. And the cardiopulmonary science degree did fall under that biological science.
Yeah. Okay. Sounds good. I have a feeling, yeah, it's true. We usually have to send.
We also have a point of care coordinator that's actually a laboratory degree that oversights it. So it wasn't an issue for us either way.
Okay. So, yeah, we've gotten less and less approvals for our people, and they generally have to have, that actual degree, and then they have to pull transcripts and stuff, but yeah.
Yeah, I think the only issue we had was I think it was in 2016 or 2017, they had us, we had a couple of people that were doing trainings that were no longer allowed to do the initial trainings because they didn't have bachelor's degrees.
Yeah. Same here.
The other thing too is that if you're encountering staff that don't have the right bachelor's degrees, the schools will be able to help you out by coming up with some sort of advanced technical certificate, which would basically say if CAP says you need 10 more credits in the biological science to qualify, here's the courses and here's the certificate proving that you did it.
Oh,
okay.
that's a good idea.
Yeah, and Dan,
Right.
the state loves that, Dan. The state reimburses colleges for that sort of thing.
Yeah.
Yep. So, that's something you can work with. I would be happy to work with you on that because I get reimbursed for that.
Oh, yeah. No, that would be very attractive. Okay. It's just something to consider when we're talking about bachelor's degree, because it's like, it's not really helpful if it's just any old bachelor's degree sometimes, but okay. Yeah, good idea.
Plus, like, for me, this is Misty again, us putting together our bachelors currently, like, then I can make sure that the sciences that they need are in that program. So when they graduate with a cardiopulmonary science degree, it's efficient for that purpose.
Correct. Yep. I agree.
That's important. Misty, correct me if I'm wrong. You had mentioned one time that the state was pushing back at colleges that were trying to convert an existing ASRT program
Yes.
to, okay. Could you
I was gonna actually bring that up because of what I think it was Aaron brought up about having, just a 4-year degree. We pursued trying to just switch our AS program to a BS program, strictly from AS to BS, and get rid of the AS and just have a bachelor's program. The students would come in with basically their AA, have their first 2 years done. Their second 2 years would be the cardiopulmonary science degree, and then they would graduate with a bachelor's. When we looked further into that, the Florida Department of Education will not allow you to get rid of the AS program that you currently have to start a full, bachelor's program at the community college level.
Right, so what that, Misty, correct me if I'm wrong. So what that means is absent, I'm trying to think of the downstream ramifications of that. So now you're saying everybody who's an existing AS program really wants to go with just the 2+2, right?
Correct.
Okay, the state's really not.
Unless if the state was to change and we went to bachelor entry, then they would have to change that stipulation or standard or whatever it was that will prevent us from going to a straight bachelor's degree. Because that was our intent, was to do a straight bachelor's degree. That's what we wanted. That's what the school wanted. And then there was that nix. We couldn't do it because Department of Education will not allow you to do that.
Gotcha. Interesting. Hey, listen.
Crazy. I have a question. Would they let you, is there any kind of bridge program at all in Florida?
What we're doing is we have our AS degree, and then we'll have a second one that they can go into for a bachelor's that's all online. And that's what most of the community schools are doing. So they would basically do a 2+2 program.
I was wondering if there's a way to make it so that so often programs want a lot of prerequisites anyway. If there's a way to have them do a year of prereqs, all of those things that they need to really get into the program, that 2-year RT, and then being able to take that last year, as a partnership with another university to be able to provide that final year. Does that make sense?
There's only 2 schools in the state of Florida that have strict bachelor's programs, Nova and FAMU, and that's it. And Nova does it online, but FAMU does not.
So then the question is, can we get more universities involved?
Well, the University of Central Florida had a program and they got rid of it 10 years ago.
Yeah. And that can be tough, Aaron, because
And
universities.
you're going to lose out on all of our schools. We'll lose students.
Yeah, universities can be tough, Aaron, because universities, respiratory programs are expensive. And if they're a university without the help of Perkins money is going to fund a respiratory program, they're going to expect a lot of enrollment. And that can be very tough to deliver, especially when you're competing against a 2-year program down the street. And that's why if you look at a lot of the programs that are closing or struggling, they tend to be the flat 4-year programs. So, hey, listen, everybody, our time is growing short. So if I could, I just want to make sure everybody got their question answered in the chat. My counterpart, Gene Mackin, is currently going through every database he can find to see if we can track down that information on the number of BSRTs in Florida nationwide. I'm not sure he's going to be able to do it before the end of the call. Mark, I wanted to circle back to Mark. And Mark, do I understand correctly? You're kind of proposing a market-driven solution. Do I understand that better? Drive this more from an employer industry push.
Yeah, exactly. I mean, we have the RRT to look at simply for the success of that. And we've heard from others besides myself on this, that they're pretty much just hiring registered respiratory therapists. We kind of talked about how CRT is going away as a thing of the past. My staff here is entirely registry eligible. Many of them bachelor prepared now. So, and I'm hiring more bachelor, and again, preferentially, not that I won't take all comers pretty much at this point, as long as you're qualified and good. But again, prefer to have bachelor degree therapists, and wonder again if there's opportunity, as we've seen with the RRT, to move forward and do this in another way.
That's a good point. So really, make sure I understand this correctly. there are three possibilities that kind of emerged from today's discussion. One is and each of these has advantages and disadvantages. So I'm not advocating for anything. I'm just sort of listing them. So you have let's just go to a flat BSRT as entry level, similar to what New York is proposing. Let's go to some sort of tiered licensure to do it like a 2+2 model. And thirdly, and I think this is what Mark speaks to, is look at a market-driven model that would basically say, let's encourage all employers to require or begin to require the BSRT, similar to what they did with the RRT. Are those the three models we could be looking at going forward? So as my team starts to sort of chip away at this white paper, those would be sort of the three base pillars we can start looking at.
Yeah, I think that would be the three pillars, but I also have a question, Mark, on the driving it from a standpoint from the industry. I agree with you that that's definitely normally an effective mechanism. How much support are most of the facilities going to have from their administration to do that and to compensate the individuals for the BS degree?
Again,
I know
I can only, it's a good point. I can only speak from here that we have strong support for it. And again, we're working on 5 times magnet from a nursing perspective. So that's well enculturated as far as the organization goes. And we're seen in a similar vein as our nursing partners. So again, from here, I can say strong support. For others, I really can't speak to them. That would be a question maybe we could pull a larger group.
Yeah, I thought that might be something that would be interesting for us to look at. And also, I think it kind of ties into with the BS level, working toward being able to bill as well. That may motivate some of the administrations as well.
Good point.
I think right now with the environment is a great time at least to hit the administration, at least where I'm standing, but I know that was an issue in the past. That's come up as could be a barrier, that administration would be like, well, balking at having an all bachelor's, staff. I think at this point, they'd just be happy to have staff and no travelers.
Amen.
Hey, Steve, it's Gene real quick. I'm looking at the AARC Human Resources Study. The only thing I can find right now is national numbers. So I don't know how well they compare to, just looking at the state, but under 25% nationally have reported that they have a bachelor's, and of those with advanced degrees, only about 24% are in a health related field.
Okay.
That's interesting. So in the remaining couple minutes we have, is there anything we want to reach out to either FREN or FRLN or the student consortium as far as getting information for the next meeting?
One question that Gina had asked me to bring forward, and I know it's not really related to the bachelor's degree, but with the people on the call, they would probably be the most in the know. She continues to have questions about the possibility of students extending some sort of student licensure, or the ability for students to work, especially in times of surge or in need of staffing issues or whatever. And, is there any chance of that occurring?
Okay. I know, Dan, I tried to champion that twice myself. Once through the FSRC, really got nowhere. A second time, I tried to do it with Georgina, and I tried to do it in Indian River with the support of a friend, and got shot down. And I know Dan Venti at Tampa General put up a gallant fight, but got summarily dismissed by the Board of Respiratory Care, who said, listen, to do that, you'd have to open up the Practices Act.
Mm-hmm.
So I think one of the things we got to look at maybe further down the road is, listen, if we're going to open up, if we have this white paper and the best option from the white paper says open up the Practices Act. If we're gonna open it up to that, maybe that's one of the things we should also include in the discussion. I don't know. But I struck out 3 times with it, Dan, so maybe somebody can take another run at it, but I'm not optimistic.
Yes, I mean, that's what I thought, but, and then in exactly the train of thought that you were thinking. Might be something in the back of your mind that if that is required to move forward with this, we may want to consider some sort of language that would maybe allow us some ability to have students do limited patient care of some sort, or in times of surge, or even just in normal.
Normal time, yeah. Very good point. So I'm definitely gonna make that note. Well, listen, everybody, unfortunately, our time has come to an end. Thank you all for attending today, and, excellent discussion. I will send out, I'd like to meet every month for at least a couple of months. I'll send out a meeting reminder. I look forward to meeting again on this soon.
Thank you.
Take care,
Thank
everybody.
you.
Hey, Steve, thanks for moderating this.
Thank you.
Take care, everybody. Happy Friday.
Yep.
Happy
Bye.
Friday.